This is Health Matters, a podcast from Mayo Clinic where we discuss the latest medical advice, news, and research to help you live a happier and healthier life. My name is Kristen Meinzer. I'm a writer and journalist, and this episode, we are talking about AI and cancer advancements. AI is everywhere now, including your doctor's office. And whether you love AI, hate it, fear it, or are simply curious about it, AI is poised to dramatically change the healthcare landscape, especially when it comes to cancer research and treatment. So, is AI going to make our wildest dreams of curing cancer come true? And how can we be sure AI is being used responsibly in our care? Here to parse out the research is radiologist Dr. Matthew Kolstrom. Dr. Kolstrom is a professor of radiology at Mayo Clinic College of Medicine and Science in Rochester, Minnesota. He's here to tell us all about AI's capabilities in medicine, which parts of healthcare still need the human touch, and what AI means for the future of cancer treatment. Dr. Matthew Kolstrom, thank you so much for joining us today.
Thank you. Great to be here.
We're so thrilled to have you here for this topic that a lot of us are curious about. Some of us are a little bit trepidatious about, and I think you're going to put a lot of folks at ease and you're going to clarify a lot of things today. So let's get into it. When most of us encounter AI in our daily lives, it's usually through ChatGPT or Claude. But when we talk about AI and cancer research or cancer care, I imagine we're talking about a different version of AI, something that's not about large language models. What kinds of tools are we talking about when it comes to your work?
One of the key elements in terms of how we approach AI in healthcare is it's really centered in our primary value. The needs of the patient come first. And with this, we're using these tools to do a couple things. One, really critical one, is we unlock data in different ways. I'll just give one quick example on how what we do today can be so much improved with AI in terms of getting better diagnoses for patients. We just recently launched a clinical trial to try and identify patients with early stage pancreatic cancer. The problem currently is that most patients with pancreatic cancer are diagnosed late. And that late diagnosis means most patients' survival is only 10% at 5 years. We believe that we can actually move the needle and start to diagnose patients earlier using AI. Our team took CT data of patients that were diagnosed late and then went back in time, 18 months to 2 years earlier, and trained a model on the CTs for those same patients. And with this, start to pick up little signals in the pancreas and the CT imaging that allows an early diagnosis or try to understand risk for developing pancreatic cancer in those patients. And so with this, if we can make that diagnosis earlier, we can actually improve survival to greater than 50% for all these patients that develop pancreatic cancer, and a profound impact in terms of how patients confront the disease and give them a chance for survival.
50% is enormous versus 10%. That's incredible.
It is incredible. I'm a radiologist. We've tried multiple different ways to screen patients for pancreatic cancer, and it always fails. My sensitivity for early stage pancreatic cancer is about 50%. We train the model, and its sensitivity is 97%. So a big difference. Challenge is me plus the model is still 97%. The model performs at a very high level. And so we believe, and we're going to learn, that maybe we can start to develop a really effective screen for patients. And we're starting with patients that have a higher risk for pancreatic cancer so that we can learn, in that population how well it performs. So this will be patients that have a family history or have, maybe a recent diagnosis of a type 2 diabetes in an older patient. And that starts to maybe tip the scales a little.
Wow. So is this kind of screening methodology widely available now, or is it still in its very earliest stages?
You can pick up some cancers, but to do it at a population level, really difficult. So it's in the earliest stages. And this is one of the key elements in terms of how you approach building AI capabilities into clinical care, is you have to do the research, find the model that works, start to validate it against patients that ultimately develop pancreatic cancer, and then do a clinical trial. That clinical trial builds the evidence, shows how we would do it, and also work out all of the, I would say, clinical care pathways to help patients as they are enrolled in this trial. You can imagine you enroll in this trial, and then we come up with the finding that maybe there's a risk for pancreatic cancer. What do? You can't just say, hey, you've got a risk for pancreatic cancer. What you need to do is put them into close follow-up so you can actually monitor them over time and pick up a cancer if it develops. And there's going to be patients where the model's incorrect and the risk is low. So we have to be able to learn about how to say, gosh, and we've screened you for 2 years. We think your odds of developing pancreatic cancer are actually low. And this is where the model is going to have a false positive.
Got it. So right now we're in the clinical trial stage with AI models for pancreatic cancer. But as these clinical trials progress, we'll learn more and more and more. And then hopefully AI modeling and screening can be used more broadly with patients who may be in at-risk populations.
Exactly right. And this is one of the promises of AI. You know, we talk about early diagnosis and detection, interception of disease. It requires these models to be built, tested, validated, and run through clinical trials. And so that patients will understand how we're using AI in their care, and they know we can actually present data that says this model is 97% specific. Your risk is, whatever it is we determine in terms of how we build the model and learn in the clinical trial. And then they'll trust how it's being used in their care.
Got it. Question. I'm not a computer scientist. Is this AI modeling actually new, or are we just more aware of it because the popularity of consumer level AI tools makes us, more familiar with the term AI now?
If you actually go back in time, we've been working as an organization in artificial intelligence. Maybe around 2015, we started to build teams internally so we could actually start to learn how to do machine learning. It's kind of the pattern recognition of AI. So imaging is a good example of that. We have scientists that are working alongside clinicians, and they've been solving problems with AI for more than a decade.
Oh, wow.
As an organization, that approach has led to internal development of more than 150 models that we've developed and deployed internally. We have commercial ones too, where people have developed tools, but our teams go after those hard problems in healthcare, find out how to build models, and then it's a huge lift, but we've learned how to do this, to deploy these, put them into our normal workflows so clinicians can use these tools.
When you say 150 models, are you referring just to pancreatic cancer or a broader span of uses?
Yeah, so 150 models, it spans the entire problem list of what we have in healthcare, from how do we get information in front of our clinicians efficiently, so data extraction and serving up insights for clinicians because they do this mentally every day. Now we can build tools that simplifies that for them, deploying things like ambient listening so that we can actually do auto documentation of a visit. And one of the key elements of that is now the patient is actually having a dialogue with their caregiver, and it's capturing that information, generating a note automatically instead of having the clinician type at a keyboard or write on a piece of paper and then somehow translate that into a documentation or a clinical note afterwards. So doing the work that we want to do, but now returning our focus to patients is a huge win. Getting into the cancer care space, doing early diagnosis of pancreatic cancer, learning how to identify prostate cancer, think about how we can identify patients that are at risk for breast cancer. It covers that entire landscape of how we can really change how we deliver care in cancer care.
So, is the AI technology we're using ready to cure cancer? Not quite, but it is capable of spotting patterns that humans often miss. Right now, Mayo researchers are running a clinical trial with AI to better screen for pancreatic cancer. Radiologists could go from detecting 50% of cases to nearly 100%. And early detection means better odds at surviving long term. Of course, this technology takes time to hone. Luckily, Mayo Clinic has been working with AI tools for over 10 years, from patient administration to the next frontier of cancer research. While feeding these AI models a bunch of data doesn't seem like the most personal approach, it can actually help deliver the next level of individualized care. We'll discuss that next. What advantages can AI offer that human beings cannot?
I'd say the pancreatic cancer example's illustrative of our human eyes. We see things that we can pick up on imaging, and if you look for certain specific findings, an anatomical change, a small growth, pretty obvious that might be a concern, potentially a cancer. But if you actually train models on patients that develop a cancer, the model might actually identify features in the tissue that a human eye just can't see. So maybe it's changing in the echo texture for ultrasound. Maybe it's the attenuation in how the organ looks relative to background normal pancreases, for example. It can tell the difference because it's looking and training on features. And then with the human added to it, you can make that judgment, well, that's a normal pancreas. I think it might be just slightly abnormal, but I wouldn't consider that to be a worry. So you actually add the clinical experience of having looked at, thousands or millions of images on top of that, then we're better together.
So it's not just relying on AI, it's the AI and the medical team working together, and together they can be stronger than either one on their own, is what you're saying.
What we believe is that we can bring these types of capabilities with AI to our clinical teams, and then they can use that as another tool, basically, in how they help patients. Is there a signal that they should be concerned about? Let's kind of build that into the workflow and care of patients. Every bit of this really just allows the clinician to be armed with the right clinical knowledge, the right imaging understanding, what we know about what that specific patient needs. And we really get to that, personalized care with the addition of these tools.
We've been talking a lot about individualized patient care, about screening and diagnosis, but what about treatment? Does AI factor into deciding we're going to do this treatment versus this one?
You've actually just touched on the next phase of AI discovery and opportunity. Currently, in the care of patients that have a particular diagnosis, you follow guidelines. Let's try drug A first and see whether or not they respond, usually based on a lot of different factors. But in the background, we don't know if that patient's going to respond. And so there's a trial period of that medication and see, did the patient's tumor or whatever it might be respond to treatment, or did it progress? We believe that if you actually are able to build basically an understanding of the types of patients that respond well to therapy, get deeper into the data, maybe get into the genomic profile of a patient so we understand the molecular basis for response, then we can start to link those data points together and get to the right therapy the first time, instead of following a guideline or whatever it might be in a trial period. So let's see if we can up front get to a better choice in terms of a therapeutic.
That really does seem to drive home the point that AI can help with individualized care, not just, in patient practitioner interactions, but individualized care in the sense that your tumor is behaving this way versus how someone else's might. So we're going to do A, B, and C versus C, D, and E, like we normally just would off the top of our heads. So it's really treating the patient like they are one of a kind each time, right?
Yeah, you're right. One way to think about it is the way a clinician actually determines treatment for patients is based on their clinical experience and knowledge around a condition and how patients like the one they're seeing that day responded over time. So they actually map that patient against their experience. If we actually do that mapping from a data perspective, we can actually take that patient and map it against the cohort of patients like them, maybe same diagnosis, maybe similar genetic profile, maybe similar molecular markers, and then actually look at that patient population to determine who responded to what therapy. And so you can actually basically mimic how a clinician thinks about their experience in the treatment of patients, but now arm them with additional data and maybe go even deeper into the complexity of the types of patients that they treat.
Wow. And I imagine that helps advance the research. When you're seeing this type of patient reacts this way, it gives you a better understanding of cancer biology and different populations and how they react to different treatments and so on.
You are exactly right. And so one of the things that we can do uniquely as an organization is, one, we can map patients against other patients and think about that, and then that can lead to new hypotheses in terms of how you think about how they are managed and treatment options for them. You might even think about a new clinical trial based on what you map in terms of that patient and their particular type of cancer and cellular markers they might have. We can go a step further as an organization, which is really exciting. Our platform data contains millions of patients, and that data is organized in a way that we know the longitudinal outcome for all of those patients. We have a diagnosis, we have an intervention, we can characterize the patient, and we know the outcome. So if you think about that, you could actually take the patient that you're seeing and run a synthetic clinical trial against different treatment arms. And so you can say, what if I tried treatment A? What do I think that looks like relative to the entirety of patients contained in our platform that are very similar? And then I'll map that against a different therapeutic arm and say, well, you know what, over time, this patient cohort did a lot better. In fact, the data really shows a big survival benefit. And so we're actually building those synthetic clinical trials today to try and go that one step further beyond mapping against experience and what we think might happen.
That's fantastic, especially considering how many populations have been overlooked in clinical research throughout history, that now we can use AI to say, hey, women in their 40s, this is what we know now, whereas 50 years ago, were women in their 40s even included in clinical trials, or certain populations of people of color? And because of AI, overlooked populations are now being seen as part of the core research, right?
You're right. So you can actually pull out that population and determine against real-world data how well they responded. And were they different from those who were included in the trial? So it gives you the chance to explore that and pull that sort of data out. And now, to your point, you can go to the next level in terms of how you think about managing those patients. So you can start to ask the next order question and understand what would work, in the 40-year-old women that have a diagnosis of breast cancer. What's different there? What about heart disease? What do we think about autoimmune disease? All of these different types of difficult conditions to treat, we can get down to narrower groups of people and understand how the particular patient you're actually seeing might actually respond to therapy.
Yeah. Oh, that's fantastic. It really just creates a broader reach, a greater level of care for people in general, regardless of what your background or identity is. You can now be seen in a way that research wasn't seeing you before. That's fantastic. Do you know of any research or studies that speak to the effectiveness and or accuracy of AI tools?
This probably applies really importantly when we think about using the generative tools, the foundation models, predicting and using data to augment what we do in terms of care. One of the things about these models is if you ask them a question, they give an answer. It might not be an accurate answer either based on the data that's there. Maybe it missed important data. And so what we've done, and a lot of people are doing, is build benchmarks. So if we actually are going to use a data set that says we're going to apply a model against this type of data, and we know the performance should be specifically this, we can use that and apply that large language model and say, extract these data elements and let's find out and compare how it does against the truth. And so those benchmarks allow you to determine how well it performs and determine whether or not it actually works for us clinically. Turns out, you can't just apply a model. You have to do a lot of work to make sure that it pulls data correctly and surfaces data appropriately. It isn't okay to just be close in healthcare. We have to be accurate and make decisions based on the right data. And so those benchmarks, all the research around doing that allows you to compare between different models as you use them. And as they evolve and get better, determine whether or not it truly got better or not, or do we have to, react to it and change what we do in terms of how we're using those tools?
So it sounds like it's always evolving, and there are folks like you working to perfect AI models all the time and make them more and more useful, more accurate, more scientific, and to really just do things that humans can't even do. But on the flip side, are there parts of cancer research or care that AI models just will never be able to replace, that at this point or in the future, only humans can do?
I would say that healthcare is intensely personal. I think the trust, the dialogue, the relationship that our providers have with patients will never be replaced. So if you say, well, what does that mean in terms of how we deliver care? I think one thing that we all recognize is that if somebody actually understands who you are as a person and you explain to them how you're caring for them, what tools you're using, that human element is irreplaceable. If you actually go to the level of decision-making about what to do, and you can do this yourself if you use these consumer models and ask a question, what should I do? It'll give you options. Making the choice in terms of what to do is human, because there's a lot of factors involved in how you decide what to do. You could offer surgery, you could offer radiation therapy, you might offer chemotherapy. It's going to really depend on that person, what they want in terms of their care, and everyone can make slightly different choices, maybe slightly different outcomes, but that choice is absolutely critical, and having that dialogue around decision-making, that part is always going to be human.
Along with that line of thought, some people out there are a little bit afraid of technology. They might complain, gosh, now when I go to the fast food restaurant, I don't even get to talk to a human. I have to deal with this machine instead. For the folks out there who are afraid of the machines, afraid of the AI tools, do you have reassurance for them that they aren't just going to be trapped in a computer model for the rest of their lives and that they're going to lose all the human touch?
Yeah, there's ways to do it wrong, that's for sure. I think the component that as we're learning how to use these tools is giving patients choice in terms of how they work with these types of tools. For example, when we use an ambient listening tool in the conversation, ask the patient, do you want this to listen in and capture our discussion or not? Do you trust it? If you don't, you don't do it. And you can fall back and do things manually. So I think every step of the way, patients need to really be engaged, understand as best they can. If they don't understand AI, you've got some explaining to do. To say, here's how we're using this tool, here's what we know about it, and here's why. If you can explain the why for patients and why this is better for them, and you get to the detail, they say, okay, I get it, then they can make an informed choice. And I think getting to that level is critical. we all have fear for how AI might be autonomously running and making decisions for us. We don't really want that in healthcare. We want people that are invested in us to have that discussion so we can actually have faith in the choices that we make, and it's the right thing for any individual patient.
So that patient who is a little bit suspicious of AI, who says to you, this all sounds fine and good, but what's in it for me? What would you say to that patient? Not necessarily trying to change their mind, but to maybe reassure them that some AI tools might result in better patient care for them.
Yeah, I think it really depends on the situation. So if somebody, for example, is trying to understand if we apply, say, a cardiology model that picks up, risks for atrial fibrillation, can we explain to them what we're using, what the actual odds of this helping them are, so they can understand, gosh, I could choose to go on a blood thinner today and to avoid getting AFib and potentially a stroke 6 months from now. Most of them say, all right, from what you've told me, maybe that's the right choice. I'd like to go on that blood thinner, even though I don't have AFib today, but you've told me there's a 95% chance that I'll have it in 6 months. I can avoid a terrible event. So you actually can frame it in a choice and then understand why that's important to them. It goes to early detection of disease. Can we say, here's what we're worried about and here's why, so they understand what your concerns are. And then if you actually get into risk profiles in genomics, what does that mean? How do we explain it for them and for their family? Because that's when you start to be concerned about sons and daughters and grandchildren and how that might be impactful. And so you do the work to explain and translate that into real impact for them as an individual.
That's great. Bringing the humanity to the computer science. If you're still wary of AI in medicine, don't worry. AI is not replacing physicians. It's just giving them another powerful tool in their kit. Instead of treating patients according to general guidelines, these research models could link data points to eliminate unnecessary therapies and find the right one for you faster. Pulling from a diverse well of real-world data also helps eliminate gaps in research that historically overlooked certain populations. But AI is not perfect. While AI can detect human errors, it's crucial to have experts test the tools time and time again until they can be sure it's accurate enough to use in healthcare where the stakes are high. And patients should understand how it's being used and have a choice in whether they want it involved in their care. So let's dive into what's next in the research and how to ensure it remains ethical. Let's look into our crystal ball. What do you think the next 1 year, 5 years, or even 10 years are going to look like in terms of this technology?
We do a lot of thinking around this, because it is important to try and chart a path forward. If you think about what it means in terms of diagnosis, we're going to get much better at identifying risk, early detection interception, so we can reduce the morbidity, the complexity of diagnosis because we catch it earlier. Individualized treatment approaches for patients so you can actually get to the right therapy the first time. The operational side of healthcare, I think we can take down some of the burden that all of our clinicians struggle with in kind of making sure that they have a full understanding of a patient, that they can use the best information available in the literature and what we have in our own organization in a more nimble way. They can have, I'd say, the bandwidth to think about that next clinical trial, to write the next chapter in healthcare using these tools, because now they can think a little bit more instead of just doing work to get that through the day. So it opens up an opportunity for discovery. I think one of the great opportunities and I think responsibilities that Mayo has is we can do these things. We can build these tools. We can learn how they work. We can share our knowledge. And then we can actually share it with the world And with this, I think the opportunity to elevate healthcare globally is incredible. If we can start to share what we're doing and help other organizations that don't have the resources to do this work so that they can take care of their patients at the right level is a huge benefit to people globally. I'll just give you one little example. We're building what's called a fusion model with cardiology data. And the way this works is you take an ECG, the electrical signals of the heart, diagnosis, and in the same patient that might have had an echocardiogram and the report, and you embed them together. You kind of feed them into the model at the same time. And so what happens is you build this on a large number of patients, call it, hundreds of thousands or 1 million patients. It learns how to link these things together. So now if you can imagine that you're in a part of the world where echocardiography is not available, now you can just feed an ECG and you actually get the echo result, or even see what it might look like from an imaging standpoint. So you use a simple test to unlock the complicated one with these fusion models.
Wow, that's fantastic for medical access in places that are maybe in less developed parts of the world also, right?
Exactly.
Okay. Everything we're talking about makes me very excited for what AI is doing and can do, but I'm going to play the naysayer here for 1 second. For the folks out there who are thinking, but AI isn't perfect. AI can come up with false positives. AI can be hacked. What happens in any of those scenarios? Isn't that creating risk for patients that maybe outweighs the benefits? What would you say to that naysayer who is asking those questions?
If you don't use tools correctly, no matter in what way that they're designed, they won't work in the right way. So I think it's the responsibility to, one, design these things correctly and understand how they work. And then people have to understand where they add benefit. And so that becomes the responsibility of the person that's using the tool, delivering the care. And that's where, if you think about the rapid change that we're going through, the responsibility really lands on the clinician or the caregiver to use these tools appropriately. So there's something to learn. And so the naysayer could be correct. If you treat it as a black box, you don't know how it works and you apply it, you'll use it incorrectly. So one of the great things about everyone I know in healthcare is they feel a really strong responsibility to provide the best possible care they can for patients. And with that, how to use tools. And I'll just add that if you actually talk to everyone, a lot of caregivers are skeptical of AI themselves. And so they make sure that these tools work in a way that really adds value for them. So they want to make sure that they're not guided in the wrong direction as they use these tools. So we have a lot of checks and balances in terms of how we use these tools as we kind of go through this incredible time where change is incredibly fast.
That's great. Because if everybody using AI was just bowing down to it, saying it's the be-all, end-all, it will solve all of our problems, there might not be folks looking for things that need to be fixed or improved in AI. So when you say that there are some folks out there working in AI who are still skeptical of AI, that's very reassuring, I think, to a lot of our listeners. That's great.
I think we start off with a healthy dose of skepticism in our whole team. As we do it, we test it and make sure, do we think it's doing the right thing? Are we going after the right problem? And then the real test of all of these models is as you put them into our workflows with our clinicians, they'll tell you if it works. They know what's the right thing in the care of patients. They'll say, it's helping me or it's not. If it doesn't work, you go back, you do the retraining, you make sure that it works. They're the test in terms of whether or not you should actually deploy these things.
What safeguards or ethical considerations do you want your field and colleagues to be mindful of as this technology advances?
I look at, one, you have to stay centered. For us, it's our primary value. The needs of the patient comes first. So how do we make sure that we do everything in alignment with that? And that's how our whole team approaches this. I think the safeguards, if you think about how new discoveries are translated into healthcare today, every one of those new discoveries has to be done in the same way. You have to prove that it works. You have to validate that it's valuable and test it against real populations. Same thing applies for any other tool, whether it be AI or some other approach in terms of how we change or improve healthcare. So I'd say from an ethical standpoint, you need to build models that represent the population so that they apply appropriately. You have to measure and compare and make sure that that's true. Make sure that as you look at subpopulations, that you make sure that it really applies to the person that you're trying to help. Make sure you're not biased. Everything we develop has bias built in, no matter what. So you actually have to measure it and show that you're using these things appropriately. From a trust perspective, every organization is going to have to make sure that they know who is responsible. And this is an important point. We don't just deploy it and then use it. We deploy it, and whoever is the final, arbiter in terms of what should be done bears responsibility to use it appropriately. And so I think that part, that responsibility, learning how to do it well, is really what's, the responsibility as you build these so you can do it appropriately and safely.
Once again, the human needs to work side by side and in cooperation with the AI. What use of AI gives you the most hope for the future?
One of the things I think that is really exciting for how we care for patients is if we can get to the point where we are able to identify patients that have risk for disease or develop early disease, and we can address it early, they get to avoid the entire complexity of a late diagnosis, difficult surgeries, all the things that come with that. It also reduces the total cost of healthcare if we get to the right diagnosis early and to the right diagnosis first. So you actually start to decrease the cost of healthcare for the individual and for the country, and then globally, improve healthcare. So I think there's just so many things that layer on top of all the work that we do that translates to a massive impact.
Oh, that's fantastic. So hopeful. Also saving money. Early diagnosis, better outcomes, less traumatic treatment. All of that sounds fantastic to me. I recently had, for my annual mammogram, normally what I have to do is I have to get a mammogram, and then they always call me back and say, due to your dense breast tissue, we need you to come back for a breast MRI. And this year, what they did instead is they said, as we do your mammogram, are you okay with us enlisting an AI tool to more closely examine your breast tissue? Between the mammogram and the AI tool, we will not need to do the MRI afterward. And I was just amazed because normally I have to take a half a day off of work for each of those visits. And this year, between the mammogram and the AI tool, it was just one visit. And I was like, please always use this AI tool on me going forward. To me, it felt like the future. I was like, yes, this is amazing.
It is the future. If you actually look in the UK, they had a rule where 2 different mammographers needed to do every mammogram. So to make sure that they get to the right sensitivity and pick up cancers that you could miss. And so now they're exploring using one radiologist plus AI as the second, check in terms of the screen on patients.
Oh, that's great. Oh, fantastic. Well, Dr. Karlstrom, thank you so much again for your time and expertise. Really enjoyed our conversation today.
I did too. Thank you for doing this.
Love it or hate it, AI will absolutely transform healthcare over the next decades, from catching cancers before they can spread to helping doctors identify the best treatment for each patient. It'll also be exciting to see AI make healthcare more accessible internationally, especially in places where imaging equipment isn't as available. AI is not a magic wand for all the ailments or biases that plague our modern world, but it could make healthcare cheaper, more efficient, and less of a pain. And that potential is worth looking into. Okay, that's all for this episode. But if you've got a question, a topic suggestion, or a follow-up question about this episode, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more Health Matters episodes and resources, head to mayoclinic.org/Health Matters. And if you found this show helpful, please subscribe and make sure to rate and review us in your podcast app. It really does help others find the show. Thanks for listening, and until next time, take care and stay healthy.